Welcome to today's webinar on wild-type TTR amyloidosis. My name is Isabel Lusada, and I'm the CEO and founder of the Amyloidosis Research Consortium. Just to get you kind of located with the format of this meeting, you'll see that there are a number of screens within the screen you're looking at. And you can adjust the size of those. You can make the presentation larger, or you can make the speaker view larger. There's also on the right-hand side, there's a question and answer box, and feel free to write in questions. We'll be saving the last 15 minutes of the talk to answer questions, and so we'll be getting to those then. There's also additionally a resource window, and you can tap on there and see the resources, additional resources that might be helpful. So next slide, Laurie. The Amyloidosis Research Consortium, ARC, is a nonprofit foundation, and our mission is to accelerate the development and access to new and innovative treatments for systemic amyloidosis and improve quality of life for patients. We do this by building strategic partnerships with all the stakeholders that are involved in amyloidosis research. And next slide. Four main areas of focus are improving the speed and accuracy of diagnosis, increasing the understanding of the biology and natural history to identify new treatment areas, accelerating regulatory approval and also the reimbursement of effective treatments for patients, and enhancing care and quality of life for patients and caregivers throughout their amyloidosis journey. And as part of that last area, we have developed a program called ARC Talks. It's a webinar series that's hosted about every 6 weeks. And I'm absolutely delighted today to introduce you to Dr. Martha Grogan, who is world-renowned in the amyloidosis field. She is the founder and director of the Cardiac Amyloidosis Clinic and a phenomenal physician. And I'll hand over to you now. So thank you, Dr. Grogan.
Thank you, Isabel, for the kind introduction. It's really a pleasure to be here and wonderful to see that we have so many interested people joining us. So we'll just dive right in. We're going to talk a little bit about cardiac amyloidosis, what is normal heart function, what is transthyretin or TTR, how does TTR affect the heart. We are going to talk about explanation of heart tests, what are the current and emerging treatments, how do you know if your heart is getting better, and what can you do to help your heart. At the end, actually, you'll see a link. Some of you have seen the various educational videos that we have, and I have a link to these with even more detail. But just as a refresher, your heart has upper chambers, the atria, which are the collecting chambers, and then the lower chambers are the ventricles, the ones that are really pumping the blood through your body. So the right ventricle pumps the blood through the pulmonary valve out to the pulmonary arteries. Then the blood picks up oxygen. So now we show it as red blood, high in oxygen, comes back to the left atrium, left ventricle, and then gets pumped to the body. So it's pretty amazing, the function of your heart. Well, what is amyloidosis? Amyloidosis is a condition of unstable proteins. And we have a lot of proteins in our body that usually are transporting things from one place to another. Proteins should be dissolved in blood to perform the various functions. But if the structure of the protein is abnormal, you can think of it as if it becomes defective or distorted. That's also called misfolded. Then the protein can precipitate out and form solid structures called amyloid fibrils, and those can get into the heart, the nerves, the soft tissue, kidneys, almost anywhere in the body could be affected by amyloid deposits. Important to know that there's over 30 different proteins that may form amyloid, but there really are only two main types that affect the heart. And also, I want to highlight that the type of amyloid that you'll read a fair amount about in the news that causes dementia is a completely different protein. So it is not related to TTR amyloid, which is the subject of our discussion today. And having TTR, wild-type TTR amyloid itself does not make a person more prone to having dementia. So we're going to talk a little bit about what is transthyretin, which we abbreviate as TTR. And I always like to know, where do these names come from? So it's a protein that we all make. Everyone's been, who's in the audience, has been making this protein their whole life. It's produced by the liver. And the name comes from the fact that it transports thyroid hormone and retinol binding protein, which is vitamin A for your eyes. So it transports thyroid and retinol. So that's how it gets the name transthyretin, or TTR. And you'll see that the actual protein happens to have 4 heads to it. It's what we call a tetramer. And when that protein breaks apart, becomes unstable, that's how amyloid can form. And you'll see in this movie here that should start playing in a second, I think. I might not be able to see it up at the top of the screen. We'll just wait a minute here to see if it plays. Maybe we advance one more. Here we go. So at the top, you see the liver cells. So the liver is normal in patients who have TTR amyloid. And you see this green protein being made. It's not really green in real life, transthyretin. If it breaks apart, then these subunits kind of glom together. And it's those smaller parts that create what's called amyloid. Some people say it's basically just gunk that can get into the heart or the nerves or kidneys or various places. But for today's purposes, we're mostly talking about the heart. And even though our topic is TTR amyloid, you do need to know a little bit about AL amyloidosis, especially because if you read about AL and you have TTR, you're reading about the wrong thing. And they do have very different natural histories and treatments. So AL, or light chain amyloidosis, comes from a problem in the bone marrow, where the bone marrow is making too many plasma cells and is making too many immunoglobulins, and that's the problem in that particular condition. In contrast, as I mentioned, with TTR amyloid, the protein is produced by the liver, but there's no problem with the liver. The problem is after the protein is formed. And it's important to know that we're going to talk primarily about wild-type TTR amyloid, although I'm happy to answer questions about the hereditary form too. So there are 2 kinds: hereditary, in which a person inherits a different protein structure, so their TTR is more unstable even from the time they're born. But not everyone who inherits that abnormal gene will get the disease. And it's relatively rare to have hereditary amyloid, but there are large populations of individuals at risk. So in the United States, for example, Black Americans have about a 4% chance of having this mutation. What's much more common, and probably the most common type of amyloidosis of all, is what's called wild-type TTR amyloidosis. And that's where we're really going to focus most of our attention. And the reason we put an A here is A just stands for amyloid. So when we're talking about it, you see AL is light chain amyloid, and ATTR is amyloid due to transthyretin. Wild type is kind of an interesting term. It just means it's something that geneticists use to describe, for example, a protein that occurs in nature. It doesn't have any abnormal genetic mutation. So that's what wild type means. And it used to be called senile, or senile systemic amyloidosis. However, our youngest patient was 48 when he was diagnosed. So we're not calling that senile. And I know that this audience won't call that a senile type of amyloidosis. So what is this wild type TTR amyloid? In the series to date, we've had about 90% men that get this condition, but women actually do get it, and we are increasingly recognizing that. The clues that we see clinically are a history of bilateral carpal tunnel syndrome, biceps tendon rupture, where a person might get the Popeye sign. All of a sudden, the biceps are bulging because the tendon ruptured. Sometimes a person hasn't even noticed it or had any particular trauma. Spinal stenosis, which is a condition in the spine where amyloid can cause narrowing of the spinal canal and cause pain or weakness in the legs and back pain when a person is walking. So we now know that these things can happen as much as 20 years before the heart is affected. Then patients get heart rhythm problems, atrial fibrillation, problems with the electrical system, and eventually they develop heart failure. The true prevalence of wild-type TTR is really not known, but the more we look for it, the more we find it. So I would encourage everyone, and this is what I tell all the providers that I talk to, that we really are learning a lot every day about this condition. So we need to be humble and realize that there's a lot more to learn. So now we have a poll here, and I'll leave this up for you to vote, just giving us some basic information about yourselves. Do I need to click ahead, I wonder? Lori, do you think I need to click? Because I'm not seeing any votes there. Oh, here we go.
No, I would just give it a minute. There's a slight delay.
Okay, you want to vote quickly if you can. So, not supposed to vote more than once, though. I think there's probably a way that that's prevented. So I think I'll move ahead in the interest of time, if that's okay. We have almost half of the people. So most of our audience is male, which makes sense given the topic. So our next question is, do you have symptoms of neuropathy? Is that, numbness, pins and needle sensation, carpal tunnel, spinal stenosis? I would say spinal stenosis, carpal tunnel can cause numbness, but that is a little bit different than neuropathy. But if you have any of those symptoms, just let us know about that. And we recognize that some of our participants are not actually patients too, so. Okay, so a lot of people do have some of those symptoms of either neuropathy or carpal tunnel spinal stenosis. So let's look about what happens when the heart gets infiltrated with amyloid. So here on this slide, you'll see we're zooming up on the heart muscle, and the heart muscle has millions of cells that all contract and get shorter, and that's what makes your heart beat. And you'll see in this next video that when amyloid gets into the heart, it gets in between those muscle cells. So the muscle doesn't get bigger, but you can think of it like injecting a filler into your heart. And amyloid is stiff. So your heart, which should kind of contract and then relax and be very elastic, now it doesn't have that elasticity because it has this green stuff in it that's making it thicker. And on the left side, you saw that the heart got thicker due to amyloidosis. Another thing that happens is as the heart gets stiffer, it's harder for it to fill. So you can think of it as pressure and fluid are building up backwards. Your heart is trying to fill, but it's getting thicker and stiffer. You get pressure building up in the lungs that makes you short of breath. You can get fluid in and around the lungs, and then eventually you get fluid in your abdomen and your legs and from the right side of your heart. Many of you may have experienced that you might be tired or short of breath. You may get swelling in your legs, as shown here. You might not be able to lie down at night because you're getting shortness of breath or waking up gasping for air. And you may have a cough, particularly at night. Another very, very common thing is to have heart rhythm problems. So normal rhythm, your heart should be nice and regular. The upper chambers beat and then the lower chambers beat. But in amyloid patients, especially wild-type patients, often the upper chambers just start quivering. That's what we call atrial fibrillation. Luckily, the lower chambers don't go at that same rate because you have a natural area of electrical system that kind of slows down the impulses. But the lower chamber starts to be irregular too. So that's atrial fibrillation, and we see that in most patients with wild-type TTR amyloid. Your heart might go too slow, and you may need a pacemaker. Many people end up with a pacemaker before they ever even knew that they had amyloid. The atrial fibrillation puts you at a higher risk of stroke because your heart is just quivering the upper chambers, and blood clots can form. And so there is an increased risk of having a stroke or having a blood clot going to your legs. And that's why it's so important, if you've had atrial fibrillation, to be on blood thinner generally for the rest of your life unless you're having life-threatening bleeding. And we teach people that if you're going in for what's called a cardioversion, where somebody says they're going to shock your heart. Now, sometimes that's an emergency. If it's an emergency, it's an emergency. But if it's more what we call elective, they're just planning to shock your heart later that day or the next morning, you really need to have what's called a transesophageal echocardiogram to make sure there's no clot in your heart. I know we already have some questions in the chat about defibrillators. So defibrillators are similar to pacemakers. They're wires that go into your heart, but they are fancier than that in that they can either pace your heart really fast if you have a bad rhythm from the lower chambers, or they can actually shock your heart. You can kind of think of it like the paramedics being built right in. So the defibrillator will deliver a shock in case your heart stops from this bad rhythm from the lower chambers. They're actually not routinely used, and there are certainly some patients may have them, but it's not a real common thing that we routinely recommend for wild-type TTR amyloidosis alone. But if there's another reason for it, then sometimes a patient will have it. Echocardiogram, most of you know what that is. That's an ultrasound test of your heart that tells us how thick your heart is, what's the pumping function, what's the stiffness, what's the valve function, tells us the pressure in your lungs. Cardiac MRI is a really important test. And it is often sometimes either echo or patients that get an MRI. Sometimes it's the first time that anyone has ever suspected amyloidosis. You may have a biopsy of your heart. So that is maybe not as common now because of the test we'll talk about in a minute, but still in some cases it's going to be important to have a biopsy of your heart, or you may have had what's called a fat aspirate or a biopsy of some other part. Increasingly, we're learning that if hand surgeons take out the material from that when they do the carpal tunnel release, in a certain percentage of patients, they will find amyloid. So carpal tunnel is another source, although that's not done unless we specifically ask the hand surgeon. We're going to talk a little bit about the PYP scan, or if you happen to be European, you may have DPD or HMDP, other ones, but PYP is the one used in the United States. And that's really revolutionized the diagnosis of wild-type TTR amyloid and TTR amyloid in general, because in the right situation, we don't need a biopsy. It used to be we always had to biopsy the heart, and that was not really done so much, especially when we didn't have treatments. But the key thing, and I'm going to teach you about the PYP scan and why it's so important to make sure that you probably might end up knowing more than some of your healthcare providers. But we can only use that PYP scan if we've made sure that we exclude the AL, the light chain type of amyloidosis, which requires certain urine and blood tests. So the PYP scan can be used to diagnose TTR amyloid, and I'll show you what it looks like. Here on the left side, this is basically just a chest x-ray, taking a picture of the body. You can think of it just taking a camera and somebody is standing with that camera right in front of them and taking a picture. And here you don't really see anything. In the middle you see darkness, and that's because of the spine, and this is a bone tracer, so we're supposed to have some uptake in the spine. And this would be an example of a PYP scan that was negative. On the one on the right, you see a blob on the left side where it's dark, and that's the heart taking up the nuclear tracer PYP scan. And you don't need to worry about these ratios that are here, but that's just a way that we say how much uptake was occurring. So that is a way where doctors can suspect that you have TTR amyloidosis. However, that's a kind of crude way, just looking from the outside. It would almost be kind of like you're just taking a picture of a house from the front door, but you're not walking inside. If you do a different kind of imaging called SPECT imaging, now you can actually look at the heart. And the pointer doesn't work here, but where you see a circle, you'll see green. And that's actually the left ventricle of the heart taking up this PYP. So now when I look at this, I know that this patient has PYP uptake in the muscle of the heart. So now I know that it's most likely going to be TTR amyloid as long as we've done the test to make sure it's not AL amyloidosis. So this is a little more sophisticated, but I'll tell you why I want you to know about it in a minute. So as I mentioned, we can do biopsies to diagnose TTR, which are really good. Sometimes if there's a typical echo or an MRI, we don't always have to have a heart biopsy if we had a positive biopsy from somewhere else, or we do a heart biopsy. PYP scan, I told you about that. And then the third thing that's really important, if someone tells you you have TTR amyloidosis, you need to know if you have the hereditary form or not, because that's going to have implications for your family members, and that is also going to determine your treatment options. Even people in their mid-80s can end up having a hereditary form that may not have been all that important in themselves, but could be important for their family members. So you want to make sure you've had what's called a DNA sequence, which is a blood test. So now I'm going to make you pretty sophisticated patients that I hesitate to say this. I don't know that I've ever given a talk to patients where I really encourage them to make sure that they go back to their doctors, that they did everything properly. But we are seeing that the PYP scan is outside of amyloid centers often is misinterpreted or not used properly, or the tests are not right. So now, thanks to Isabel giving me this opportunity, I'm going to teach you to know the three things that you need to ask. If someone said that you had TTR amyloid, wild type TTR, you need to know, did the echo look like amyloid? And you'll see that on the report yourself, or with MRI look like amyloid? Did your provider do the test to make sure you don't have AL amyloidosis? And there's what I called SPECT. That's looking at the heart muscle. You don't need to know exactly what it stands for, but you want to find out, did I have SPECT when I had that PYP scan? And that little tip, if you happen to have a biopsy, you also want to know if something called mass spectrometry was done on the biopsy to make sure that it's TTR amyloid, not AL or another rare type. Now, one of the things, this is also on the videos that I'll give you a link to, but you'll hear a lot about ejection fraction. And it's a number that sounds really important, and patients ask us about it all the time. But I'm going to tell you that it's really not a very important number. It's the percentage of blood that your heart pumps out with every heartbeat. So if you hear that heart failure is a condition in which your heart is not pumping enough blood to meet the demands of your body, it seems like all you need to know is that ejection fraction. It kind of seems like stock price, and people worry, oh, my ejection fraction was 48 and now it's 56, or things like that. And really, most of the time, those differences are not significant. What I care about is your ejection fraction 10 or 20? Is it around 30 or 40? Or is it 50 or above? And if you tell me it went from 56 to 62, I'm not going to be impressed. And this is a little bit complicated, but the way to think about this is when you look at the heart, here it's squeezing, as I mentioned, and then relaxing. And when it relaxes, that's when it fills with blood. So here's the heart filling with a certain amount of blood. We happen to show that as like 10 balls of blood. Then it pumps blood out, and this is the amount that it pumps out with every heartbeat. So it's that percentage that is the ejection fraction. So the reason that's so important, so in this case, it would be 60%. But here, if we look at some different heart conditions, normal is at the top there of the screen, 60%. But if a heart is really enlarged, which doesn't usually happen with amyloid, but it can happen after a heart attack or for other reasons, if the heart gets really stretched out, it might be weak. It's not pumping very much, but it's got more blood in there. So it's got more blood to pump around. So a patient might actually feel pretty good. But if your heart is small because the walls are thick, which is what usually happens with TTR amyloid, then you can pump half the blood out of your heart. That would be 50% ejection fraction, but it's half of a smaller number because you didn't have that much blood in there to begin with. So this is just the examples of these three different conditions that I explained to you. And it's a tough concept. Again, you'll have plenty of your doctors that really don't understand it very well. But the bottom line that I want you to remember is that having a normal ejection fraction does not mean that you have a normal heart. In fact, we have patients who are waiting for a heart transplant who have an ejection fraction of 55, 60%, which is normal, but it's because their heart is too stiff from amyloid or other conditions. So EF is, a little bit, the basic, range is important to me, but we care more about the absolute amount of blood that your heart is pumping around. So if you really want to be sophisticated, and so it's not a problem if your provider doesn't know this answer right away, but they can look back at your echo, or if you had a heart catheterization, you can say, well, how was my cardiac index? Because that is a reflection of the amount of blood that was pumped every minute, according to your body surface area, and the one called the stroke volume index. So these are the more sophisticated ways that we look at it. When we look at this next video, is just showing a heart that, an echo of a heart that was affected by amyloidosis. And you'll see, it might have kind of glitched there. I'll try it again. Well, bottom line is the heart gets thick, but it still usually pumps okay. And when we measure, there it's going now. I have to be a little more patient with these videos, so it just plays for a second there, which is fine. Now, when we measure wall thicknesses, a lot of you are going to be looking at your reports, and you're understandably, you know that amyloid makes your heart thick, so you're going to be looking at the wall thickness. I just want to let you know that this is what an echocardiogram looks like. This is the, you'll see the left ventricle, you'll see blue dots at the top. That's the wall of the heart. And then at the bottom, that's the back wall of the heart. That's how we measure the thickness of the heart muscle. But if you look at these pictures, your heart muscle is not uniform. It's not like measuring the diameter of a pen. It's got ripples and it's a muscle, so it's not all the same thickness. Plus, when we measure the thickness by an echocardiogram, we are making a two-dimensional measurement of a three-dimensional structure. So the angle of just the ultrasound beam going through your chest and through your heart can make a difference. If we slice your heart at an angle, the wall is going to be thicker than if we do a cut that's just straight through. So this happens to be one where we measured 12 millimeters and 11 millimeters, which would be in the upper normal range. But I wanted to show you an example that is not quite so simple, because here's a patient that has, on the left side, we have a patient who has AL amyloidosis who actually has normal wall thickness, but their heart was very abnormal because it was so stiff. And on the right side, we have a really, really thick heart. It happens to be a wild type TTR patient who can walk 3 miles a day. So one patient's waiting for a heart transplant. The wall thicknesses are 8 millimeters. The other one has wall thicknesses of 25 millimeters, and they're feeling pretty darn good. The other thing, it does not mean that you have bad sonographers doing your echo or bad doctors reading them, but here's one that I found where we measured the septum, that's the wall between the right and left ventricle, at 17 millimeters, the posterior wall at 17 millimeters, but on the same day, somebody else measured 12 and 11. And I can't show you with the pointer, but that's all because of technical details of exactly where we place that cursor. So echo is a fantastic technique for suggesting the diagnosis, but there are limitations to these measurements, and I just don't want you to worry about them too much. This slide is showing us that different parts of the heart muscle will give different measurements because it's not uniform. I'm going to skip over this. Strain is a more sophisticated way of looking at your heart. It's a great technique. It also helps suggest the diagnosis of amyloid if the sonographer and the cardiologist see a different pattern that suggests amyloid. It can be a little hard in follow-up because there are some technical challenges in making it very reproducible. The other thing, just for you to know, is, and here it did play, but we're going to pass through that one. Your heart is not just a simple, tube squeezing in one dimension. It actually twists and turns like if you were wringing out a towel. You wouldn't just squeeze it, you actually twist it and turn it. And your heart has that twisting and untwisting motion. And the reason I tell you about that is it just means that there's not a single number that will tell you how your heart is doing. You really need a cardiologist who is used to looking at amyloid to tell you if your heart tests are looking any better. And as I already alluded to, it's really best to use these tests mostly for diagnosis, not so much for following how you are doing. And we'll move on to blood tests here. Many of you have heard about troponin. That is a protein that's released when there's a heart attack, but I showed you that in amyloid, the heart muscle cells have that amyloid right next to it, so they can leak out some of this enzyme. So certainly, if you have wild-type TTR amyloid, you still could have a heart attack. But sometimes you might go into an emergency room, especially if you have shortness of breath, and someone might think that you're having a heart attack when really it's just some of this troponin related to amyloid that's leaking into your heart, and leaking out into your bloodstream. And then there's a test called BNP or NT-proBNP. That's a very helpful test to how you're doing from a heart failure standpoint, what the pressures are. It's an indirect way of telling us that in your heart. And the only thing I want you to know about that BNP or NT-proBNP number is that it can vary about 40% in a week, even when everything is stable. So if somebody's NT-proBNP is 3,200, then it goes to 3,800. That's not a big deal. What we're looking for, again, is it around 1,000? Is it 3,000 or 4,000? Is it 10,000? Is it 15,000? Occasionally we see it 40,000. So we're looking at big changes in the NT-proBNP, and the trend is a lot more important than a single number. Another test you might not have heard about too much is prealbumin. And that's actually a measurement of TTR in your bloodstream. And it usually kind of goes along with, for most people, nutritional status. But in wild-type TTR patients, the normal range for this test is around 19 to 38 are the numbers we get. So most wild-type patients, when they first get diagnosed, the number will be around 20 or so. And if they get put on a stabilizer, it usually comes up to 25, 28, that kind of thing. So it's an indirect way of giving us an idea of how much stabilization has occurred when you're on therapy. It's not as sophisticated as some of the research tests that we have, but that's what we have clinically. People, understandably, who've had amyloid have read about this condition and want to know how is it going to affect me? What's my quality of life, and also how long am I going to live? So before we had treatment, the average patient with wild-type TTR amyloid would live about 3.5 to 4 years after they got the diagnosis. But these were pretty sick patients seen at referral centers. So they're not just average patient, seeing their community doctor. They are sicker and they actually got the diagnosis. So not necessarily applicable to many of you today. Some patients we know progress much more quickly, and others could survive much longer. So we can use staging systems, and some of you ask about that, to get an idea of your prognosis, recognizing that those blood tests I told you about can be a little bit fickle, but we can use those simple blood tests to give us an idea. However, those don't take into account now that we have treatment. So the staging systems were before we had treatment with tafamidis, and other factors will play a role. Because as we mentioned, wild-type TTR amyloid happens in older people. I don't have to tell you, as you get older, that more things can happen to you. So you might get sick and die of something else, not necessarily TTR amyloidosis. And patients are living longer. Just this morning, I saw a patient who's wild-type TTR amyloid who was diagnosed 7 years ago. He's been on tafamidis because he was on clinical trial. And he's going to turn 91 here in a few weeks. And we had a patient last week that's 96. The other thing is, when you look at our staging systems, they're very helpful, but they're designed for large groups of patients. And so in our audience, I don't think we have too much average people here. So these are just rough guidelines, and they don't help us that much with an individual, but they give you some idea. So what do you want to do to treat your amyloid? We want to stop the source of the protein, and we have these new drugs that we'll talk about. Over time, we know from other types of amyloid, mostly AL, that if new amyloid isn't being laid down, the body recognizes the amyloid as being abnormal, and it can at least soften it up. The patient might feel better, the heart might still be thick, and eventually break it up. So our systems are pretty amazing. The human body has a way of trying to cure things, and that's one of them. We're going to talk a little bit about medications to take amyloid out of the heart, and all I really want to say is patients often focus on that. I have to get this amyloid out of my heart. But if you think about it, most of the time, if we could keep you kind of the way you are, many people who are early or more middle in the diagnosis could feel pretty well. And then if the body starts removing some, that would be okay. So far, the medicines that take amyloid out of the heart haven't proven so successful. They may be coming down the road later on. Many of you will be on water pills to help reduce the pressure and get rid of excess fluid to make you breathe better. Medicines that we usually use for other types of heart failure. These are beta blockers, ACE inhibitors, and Entresto. They often aren't very well tolerated in people with cardiac amyloidosis, including wild-type TTR. We should never say never, because really early diagnosed patients might do better. Also, beta blockers help slow the heart if it's going too fast in atrial fibrillation. So many people will need at least a low dose of beta blocker. So it could be changing in the future, but many of our more advanced patients certainly don't tolerate these medications well. But the key thing is, I don't want anybody to go and stop their medications based on anything I say today. This needs to be individualized by your doctor for your situation. So I mentioned the staging system. These tests are done at Diagnosis, and these are the numbers we use, that if the NT-proBNP is less than 3,000, and there are many different troponin assays, but the one that if it's less than 0.05 or the high sensitivity less than 65, people will live longer. If both of the numbers are higher than that threshold, people don't do nearly as well. And in the UK, they developed a very similar staging system, except it used something called GFR, which is a simple test that helps tell you about your kidney function. So we do have ways of classifying people into kind of, are you early, middle, or late stage in the disease? And that's done at the time you get the diagnosis. But again, it doesn't take into account now the effects of treatment. So we'll move on to the last and probably most important part. What are the treatments for TTR amyloidosis? So the strategies are, one, to stop the liver from making the building block, the TTR that is breaking apart and causing amyloid. And these medications, we call them silencers because they're silencing the liver. And they're pretty amazing medicines. They go into the liver and tell the liver to do everything that you're supposed to do, and make all the other proteins, just don't make any transthyretin. And they're pretty effective at doing that. Patients still make some transthyretin, but about 95% of it is silenced, as we say. And the names of those drugs that are available commercially are patisiran and enoterasin. Important for you to know that those are not approved at this time for wild-type TTR amyloid. They're approved for hereditary TTR amyloid in patients who have neuropathy. They might have cardiac involvement too, but they have to have some neuropathy. There are newer versions of both of these drugs that are now being tested, where they're easier to administer, they're a shot underneath the skin, and they are less frequent. And these are being tested in wild-type patients specifically with cardiac involvement. The next thing is to take a medication that would stabilize that transthyretin so it doesn't break apart. And that's what, so we call it stabilizer. That's what Tatamidis does, which is approved specifically for TTR amyloid affecting the heart. Diflunisal has been shown to slow the progression of neuropathy in hereditary patients. It's also a stabilizer. And sometimes we use it for very early stage wild-type patients, especially if tafamidis is too expensive, but we have to be cautious because of some side effects. AG10, some of you may be on that study, and they've given it a name, Arrhythmias. There's a clinical trial ongoing of that stabilizer as well. What about trying to take amyloid out of the heart? We call those disruptors, things that break up the amyloid. And all I can say is is really not as easy as it sounds, and we'll talk about that on the next slide. So just to review, at the level of the liver, we can try to stop the production, and those are silencer drugs or RNA interfering drugs that are shown on the left-hand side. In the middle, we have stabilizers. So the protein is still produced, but we keep that protein together so it's not breaking apart. So you still have the protein, which maybe is an advantage. And those are the medications that do that. Disruptors, there was interest, or there has been interest in doxycycline, which is an antibiotic, which might actually help with any type of amyloid, of helping prevent the fibrils from forming. But doxycycline plus something called TUDCA was shown in a mouse model to break up amyloid. And we used this a fair amount prior to when we had tafamidis. There have been some trials in humans that really haven't shown us a lot. I think there might be one that's still ongoing. So some of our patients are still on it, especially if they can't afford tafamidis. You can get side effects from the doxycycline. We don't use it too much anymore, mostly because we don't have a lot of evidence in humans that it's that helpful. Then there's a monoclonal antibody, PRX004, which is directed specifically at TTR. And there has been what's called a phase 1 study that's been completed, not yet reported. But that was just kind of to try to figure out what dose people should have, and it was done only in hereditary patients. So there could be more to come on PRX004, or there might be some of these other antibodies that try to break apart amyloid. Some of the earlier ones that had been used for other types of amyloid, such as AL amyloidosis, so far haven't really panned out despite a lot of enthusiasm initially. So this slide just reviews. And hereditary patients historically have undergone liver transplant, and probably most patients will now be treated with medications, except for some exceptions. So we have another poll for you now related to clinical trials. Have you participated in a clinical trial for your ATTR wild type in the past, or would you be interested in a clinical trial? So we'll open the polling there. Okay, so only about 10% said they weren't interested, and others either have participated or are currently participated or are interested. And I know that Isabel will, of course, be very, very happy in that regard. And to those of you who have participated, this is the only way we really make progress with this sort of condition. So we really, really thank you. It's a lot of effort on the part of the patient and their families, but it gives us good scientific evidence of which therapies work and which don't. So that's really why we have progress in this disease. So what does tafamidis do? Important to recognize that it doesn't cure disease. In fact, the silencers have not been shown to cure disease. In fact, there's not that many cardiac diseases where, especially tafamidis, where you could take a pill and it would be cured. But it slows down the progression of the disease. So patients who were on tafamidis compared to those who got a placebo had less chance of dying or being in the hospital due to heart failure. And they had less decline in their 6-minute walk than people that were on placebo. But this is truly a $1 million question that I don't blame people for asking. You're taking this very expensive medication and you want to know, is it working? And the only way I can tell you is there is no real way that you can know if this drug is working because it slows down the progression. So think about it like wrinkles. You know, if you have an anti-wrinkle cream, that's going to slow down the wrinkling and the aging on your face, but it's not even supposed to make the wrinkles go away. How am I going to know how fast I would be getting old if I didn't have that cream on there? And that's kind of the same thing in the heart. So that test I told you about, prealbumin, that can give you a little bit of an indicator. If you're relatively stable, you're not having a lot of problems, that's kind of an indicator. There's just not a simple test, and there is not a simple blood test to tell you how stable is your TTR, not a direct kind of test for that. And so unless you had an identical twin, I can't tell you for sure how much it's helping. And here to show you, this is a scientific graph, obviously, but at the top you see people that took tafamidis, and that blue line is showing you that they lived longer. But it was about 18 months before the lines separated. Up for the first 18 months, they were about the same. And then as the trial went on, more people were living on tafamidis than were living on placebo. So it slowed down the rate of death, but it didn't cure the disease. But it's a very impressive 30% reduction in the chance of dying from that condition. So what do we do about follow-up of amyloidosis? Honestly, how you feel is very important. How far can you walk? That's why we do the 6-minute walk test, or even just ask you what you've been doing. Are you in the hospital a lot? Are you requiring more diuretic therapy? Do you have to come in and get IV diuretic? What do these simple blood tests show me? What does your troponin, and more importantly, probably your NT-proBNP and even your kidney function, how are those doing? And then I mentioned the prealbumin test. It's not something you have to check real frequently, but it gives me some idea. If it goes up, that the stabilizer is probably doing something. The stabilizer usually being tafamidis. People want to know, what can you do? So I really think it's important to make sure you have the right diagnosis. I could almost bet that there is someone listening who's been diagnosed that might not really have TTR amyloid. That's just a trend that we've been seeing with the PYP scan. So make sure you really have the right diagnosis. Weigh yourself every day. Look out for fluid. Simple things like using compression stockings to push that fluid out of your legs so that we don't have to give you as much diuretic. Limit your salt and fluid. It's actually quite helpful to exercise, but you need to pace yourself. So we don't want you exhausting yourself or pushing your heart to extremes, which are going to stir up heart rhythm problems. But being as active as you can on a regular basis with both aerobic and strength training exercise is important. Some people forget to do strength training. As we age, we lose muscle mass, and amyloid accelerates that. And the best way I can tell you is that your heart, exercising won't take amyloid out of your heart, but it will make your heart, it makes it easier for your heart to function. So really your heart actually likes to pump to muscle, not to flab. It's metabolically more favorable. So in summary, for taming wild-type TTR amyloid, we have to make sure you have the right diagnosis. You should know that treatment options are expanding, and the future is really, really bright for this condition, and will continue to improve with earlier diagnosis and treatment. And I've included some resources. You probably know about most of these. We also have a Mayo Clinic Amyloid YouTube channel that has many videos up there, much of what I've said today. And just to let you know, we have a large group at Mayo Clinic, so I'm not here by myself. I have a whole team that I work closely with. Out of the 200 cardiologists that we have a core group of people that see patients with cardiac amyloidosis. And I thank you for your attention.
Thank you so much, Dr. Grogan. That was a fabulous talk and very informative. We have a large number of questions, and I'll get straight to those. The one thing I would add is that if you're interested in participating in clinical trials, we've developed a tool which is called, it's one word, myamyloidosispathfinder.org. And if you sign up to that, it will alert you of any trials that you would match. So it's a great way to keep informed of any clinical studies that are coming your way. We have had, and I'll pull up some of these questions, there are a number of questions just to start off around extra organ involvement. Can wild type affect other organs?
Yeah, great question. If we do biopsies, we can probably find a little bit of wild type, in the GI tract, soft tissues. Sometimes people will have a colonoscopy and there's a little bit of TTR amyloid. As far as causing symptoms, mostly it's the heart, carpal tunnel, spinal stenosis, and in some patients, neuropathy. Neuropathy is a tough one because as people get older, especially if they've had diabetes, they may have neuropathy to other conditions. Doesn't usually affect the kidney much to our knowledge. So the heart is really the most important organ involved. I also should say that as people get older, we know that having some wild-type TTR amyloid is not uncommon. With each decade, it goes up. And there are some people that just get a little bit of TTR amyloid in various places in their body, and it's not actually causing much trouble.
So another question is, how often do I need to have scans and blood tests? And we've had a few about what is the cadence of follow-ups that the patient should have.
It's great. A great question. Those of us who write review articles realize we don't have a lot of data to tell us. I would say many patients, very stable patients, we sometimes see them once a year with some blood tests and a 6-minute walk. I discourage people from getting a lot of echocardiograms or other scans unless I think that the echo is going to change management, unless I think something new has happened. Which would be like fluid around the heart, which is pretty rare, or patients with amyloid can have a condition called aortic stenosis. So if they have aortic stenosis, we'll be monitoring that. But lots and lots of echoes are not going to change too much what we're going to do. People that are more unstable, requiring more adjustment of diuretics, they might be having some blood tests anyway, every 3 months or so, if somebody's adjusting their diuretics or just seeing them clinically. But the PYP scan, I will comment that originally there was some idea that maybe that will help us follow up patients and see if it gets lighter, but that really has not panned out. So you don't usually need a follow-up PYP scan.
Here's another one, which was, I'm told I need a heart biopsy after having had PYP to definitively determine I do not have AL. And I think we've had quite a lot of questions on heart biopsies.
Yeah, that is great. So before we had PYP, whenever we made a diagnosis of amyloidosis, we had to have tissue from some part of the body that the pathologist reviewed and said that there was amyloid. And like anything, it can depend somewhat on the expertise of the pathologist. PYP changed that, but I mentioned that you had to have certain tests to make sure you don't have AL amyloidosis. And these are blood tests that I'm not going to go into all the details of what they are, serum-free light chains, and they are what's called serum and urine immunofixation. But the key about that is, as people get older, those proteins that can be abnormal in AL amyloidosis, sometimes people just have those floating around, but they don't actually have AL amyloidosis. So almost 40% of wild-type TTR patients will have what's called a monoclonal gammopathy. And if you have that, then you just cannot use the PYP alone, and that would be a really, really good reason why somebody's recommending a heart biopsy. Also, if things just aren't looking right, if the echo doesn't look what we call classic for amyloid, if there's just something suspicious, because PYP can be abnormal in other conditions. There are a variety of other heart conditions, and we're going to be learning more about these. So it's a good test, but it's not perfect, and the gold standard is a heart biopsy. Now, I don't want everybody to say, I have to go get a heart biopsy, but it's not wrong if somebody is recommending it to you. CRISPR.
So any updates on CRISPR and what it is?
So CRISPR is very interesting new technology. So your DNA, which determines the structure of your proteins. It's your genetic blueprint, so to speak. CRISPR is a technique that is being pursued for mostly for hereditary diseases, where if there's a problem with the gene, this is what they call a molecular scissors, and it can go into the DNA and snip out the gene. So for hereditary TTR, where the gene is abnormal, that's what determines that the protein is abnormal. That can be, in theory, and there's a clinical trial that's available, I think just in the UK and maybe New Zealand, can actually cut out that portion of the patient's DNA. Then you won't make the TTR. It would be a one-shot treatment. Now, what's the downside of that? Well, you can't put it back in if you take it out. You also, right now, it's being used for hereditary patients. Maybe it will eventually be used in wild-type patients. But transthyretin also has a role in things like your brain function. We don't know how much of a role it plays. But even with the silencer drugs, if somebody has a really low level of TTR for a long, long time, we're not sure. Could there be any consequences of that? So I think it's quite a ways away from any applicability for wild-type TTR patients. But it is an exciting new therapy, probably will first be used for hereditary patients. But if you think of the other medications we have, they are reversible. You can take them away, and then they will stop doing what they do. This is one, once you do it, it's done, you know.
So here's the next one. What is meant by preserved ejection fraction?
That's a great question. Generally, that means that the ejection fraction depends which article you read, but usually means that it's about above 50% or so, that the heart is pumping about half the blood out. And so you'll hear a lot about amyloid as a condition of heart failure with preserved ejection fraction. It really means, you know, it's heart failure because the heart is stiff, not so much because the heart is weak.
What are the side effects of Tatamidis?
That is a great question. Tafamidis, in our experience with large number of patients and in the results of the clinical trials, has almost no side effects. In the very early studies, there was a little gastric upset, sometimes, you know, a little change in bowel habits, a little bit higher chance of urinary tract infection. That was not shown in the larger clinical trial. It is one of the most well-tolerated medications. It does not cause any dysfunction of the kidney or liver or anything like that to our knowledge. And quite a few patients have been on it now because it's been approved for neuropathy in hereditary patients in Europe for quite some time. So it's really one of the safest drugs, to the point that when we were doing the ATTRACT study, and so patients are either getting tafamidis or placebo, quite a few of our, and we don't know what they're getting, and patient doesn't know, quite a few patients became convinced that they were on placebo because they noticed nothing. You know, they would take the pill and there was nothing that they noticed different. So that just shows you how really free of side effects it is.
So why are pacemakers and ICDs not commonly used with ATTR wild type?
Well, I should correct that. Pacemakers are commonly used. And again, sometimes a patient has to have a pacemaker before anyone ever figured out that they had TTR amyloid. The defibrillators are more commonly used when somebody has heart failure and the ejection fraction is really low, like less than 30%. So there have been studies that show that even if a person has never had a known bad heart rhythm or they haven't had their heart stopped, that if you put in a defibrillator, you know, acting as a prophylactic thing, it will help prevent people with that type of heart failure from dying. With what was just mentioned, the preserved ejection fraction, when the ejection fraction is above 35 or 40%, there's never been any proof that having that defibrillator will really make people live longer. So the defibrillator isn't going to cure the amyloid. And in wild-type TTR amyloid, it's not as common for the heart to stop suddenly. So occasionally they're used if a person's already had a cardiac arrest and survived it, or if the ventricle is very weak. But one of the things about the devices is, like, pacemaker is a great device if you need it. If your heart's going really slow, you're only going 30 beats a minute, or your heart's actually stopping for 6 seconds, you need a pacemaker, no doubt about it. A prophylactic defibrillator you're putting wires in your heart. The device can get infected. It can cause leakage of a heart valve. So they're not without side effects. So there's not enough proven benefit is why we don't use them very commonly to defibrillate, but we do use the pacemakers quite commonly.
So we have just time for one final question, and I think this is a good one to end on. Is it okay to have a glass of wine?
Well, we didn't correspond on this in advance. You know, it is okay to have a glass of wine. One needs to recognize many people with wild-type TTR amyloid are going to be on blood thinners. In fact, if you're not on a blood thinner, I'm going to be wondering why you're not, because usually it might mean that we missed the atrial fibrillation. If alcohol is a small amount and relatively consistent, that's fine. If you suddenly go and drink a bottle of wine, that's not going to be good. And too much wine is hard on the heart. So a little bit is just fine for most people. Most people.
So thank you so much. We're at the end of our time. We have had over 150 questions that have come in. We will make sure to get back to you and answer those questions, and we'll reach out to Dr. Grogan to make sure we get the answers right and work with her on making sure every question is answered. This talk will also be available online on the ARC website. I know a few people are having technical difficulties with the sound. It did record perfectly well, so that will be available with full sound. And Dr. Grogan, I can't thank you enough. It was a fabulous talk with wonderful graphics that made it so clear and concise to understand. So thank you so much for joining us today.
Thanks for having me.